So I think the majority of us in the community would say that patients with complex karyotype or P53 mutant disease tend to fare less well with traditional induction approaches. I think in that patient population, I would be more likely to think about giving them a liposomal cytarabine and daunorubicin combination strategy, or even an alternative induction like a combination of azacitidine and venetoclax or decitabine and venetoclax, since their molecular profile tends to predict a poor response to standard therapy. And at least with the data that Dr. Pollier is going to present tomorrow, it seems as though those patients do a little bit better with this alternative combination strategy. I don't think that that's really ready for prime time, and I don't think that's supported necessarily by well-controlled data, but it's certainly a feeling that many of us, I think, in the field have. If you have a young, fit patient, I think one is compelled to really think strongly and offer the patient standard induction therapy, even if they have relatively poor risk mutational features or a cytogenetic risk profile, possibly with the combination of the liposomal combination therapy, since that appears to result in a better long-term outcome, especially in patients who are eligible for allogeneic transplant. And that would be the kind of patient where you'd want to be able to offer an upfront allogeneic transplant. With respect to upfront allogeneic transplant, I don't think we would do that for patients with overt leukemic disease unless they really had exhausted all of their strategies. So I wouldn't do it up front, but I might consider it if I have a patient who I'm able to get into a good, deep, complete remission who has a high risk of relapse.